everybody. Welcome. Thank you so much for being here today. I'm Christine Mounds, and I'm the director of the Center for Social Science Scholarship, which coordinates the Social Sciences Forum lecture series. CS3, which is what we call the center, was founded in the summer of 2018, and we're celebrating our 5th year anniversary during this entire academic year with several special events. Today we're kicking off the spring lecture series with the special Social Sciences Forum lecture to commemorate our 5th year anniversary. Tomorrow we'll be releasing a CS3 community survey to gather feedback that will help us envision CS3's next 5 years and beyond. So please look for that link in our upcoming newsletter, my UMBC posts, and so on. And if you'd like to read more about the history and establishment of CS3, there's a one-pager over there on the sign-in table, along with CS3 swag, a sign-in sheet, so please help yourself to any of those goodies as well as the edible goodies on that side. Our next Social Sciences Forum lecture will be on March 26th at 4 p.m. right here in the library gallery. The Department of Sociology, Anthropology, and Public Health will be hosting the Eckert Lecture on Health and Inequality with guest speaker Dr. May Studina-Rosette, Associate Professor and Vice Chair, Department of Community Health Sciences at the Jonathan and Karen Fielding School of Public Health at UCLA. Her talk will be Structural Inequities in Maternal and Sexual Reproductive Health Care in the U.S. and global context. You can find more about the semester's lineup on our website, socialscience.umbc.edu. We're also on social media, on LinkedIn, Facebook, Twitter, and Instagram at UMBC-SocSci. We also have a wonderful podcast, if you all are not yet familiar with it, called Retrieving the Social Sciences, where you can find that on Spotify, Apple, or Amazon. So please tune in and listen to all of the wonderful research in the social sciences is happening at UMBC. Thank you again for being here. Hopefully you can stay afterwards for the reception, and I will now turn things over to Dr. Lucy Wilson, professor in the Department of Emergency and Disaster Health Systems, who will introduce our speaker. Thank you all.
Good afternoon, everybody. Nice to see you. I'm so very pleased to introduce Dr. Joshua Sharfstein today to the UMBC community. I've worked with Dr. Sharfstein for nearly 20 years, but even so I learned some new things about him preparing to talk today. But currently, as you can see on the screen, Dr. Sharfstein works at the Johns Hopkins Bloomberg School of Health, and he's the Vice Dean for Public Health Practice and Community Engagement, Professor in Health Policy and Management, and also Director of the Bloomberg American Health Initiative. So relevant to today's talk, I thought it was, for those of you who aren't aware of that program, since we're talking today about community engagement and higher education, it is a visionary program that is rooted in equity, evidence, and policy, and it tackles 5 really important areas that affect communities: addiction, overdose, violence, adolescent health, food systems for health, and environmental challenges. Dr. Sharfstein is the author of 2 books, the Public Health Crisis Survival Guide, Leadership and Management in Trying Times, which has been pretty relevant in the last few years, and he's a co-author of The Opioid Epidemic, What Everyone Needs to Know. But then a quick review of his numerous publications kind of gives an idea of the span of public health that he's engaged in, thinks about, and is a leader in. He has publications in health innovation, accountability, and finance, U.S. healthcare policy and child poverty, data transparency, COVID-19 education, COVID-19 and communication, U.S. public health reform, response to the U.S. opioid crisis, and near and dear to my department, public health emergency preparedness. So prior to being at Johns Hopkins, Dr. Sharfstein served from 2011 to 2014 as the Secretary of the Maryland Department of Health. And there he led efforts, many efforts, but some accomplishments were aligning Maryland's healthcare system with improved health outcomes, reshaping Maryland's hospital payment model, and optimizing data in Maryland's health information exchange. Prior to that, from 2009 to 2011, he served at the U.S. Food and Drug Administration, the FDA, and there he was Principal Deputy Commissioner. From 2005 to 2009, in Baltimore City, Dr. Sharfstein was the Commissioner of Health, and there he made significant impact on overdose deaths and infant mortality rates. Dr. Sharfstein Sharfstein has received many awards, and too many to go into right now, but of note, he's an elected member of the Institute of Medicine, the American Pediatric Society, and the National Academy of Public Administration. So to kind of personalize this person who's here today to speak to us, Dr. Sharfstein has been a trusted colleague and advisor to me in the public health arena, like I said, for almost 20 years. We first worked together, you might not remember it, but in 2006, when you were the health commissioner for Baltimore City, and you came to Johns Hopkins and spoke to my HIV clinical group about the providers becoming certified to prescribe buprenorphine, which is also called Suboxone, which is an outpatient therapy for opioid use. And at that time, it required a special certification called an X waiver, which is no longer required. But he came to advocate for outpatient treatment of opioid use in primary care settings, and he's continued to be a really strong advocate in that area to this day. So we also worked together at Maryland Department of Health for a number of years when he was the Secretary of Health, and I was a medical epidemiologist there, and we worked on many infectious disease outbreaks and a lot of issues on patient safety. And most recently, well, I guess during that time, we also spent time on the sidelines of basketball courts as our sons battled each other in basketball games, and we talked about public health sometimes. And more recently, we worked together on COVID-19 and on Governor-elect Moore's health transition team. So lots of background and lots of variety for those of you who are interested in public health as a career. So I just wanted to say that I deeply value Josh Sharfstein as a public health leader and a community advocate. And while he soars on the national stage, he also digs really deeply into local community issues. And he's not only celebrated for, like this Bloomberg American Health Initiative, but he's also a practicing pediatrician. He's a volunteer vaccinator in COVID-19 tents and many other local efforts. And as a mentor to those in the community, he uses his fierce optimism and his drive to create real positive change in our state, and I consider him a Maryland treasure. So on those words, I'm honored to have you here today to speak about putting the public in public health.
Thank you so much. That was such a nice introduction. It is a real honor to be here. I have just a huge amount of excitement coming and respect for UMBC. When I was health commissioner, I came out here and worked with the Schreiber Center to start a program up at St. Agnes Hospital. I used to come out here fairly regularly, so it's great to be back. It's such an honor to be here with Dr. Wilson. I can just tell you that my brain is aligned, that anything that Dr. Wilson says is correct. That's why I had a hard time kind of processing that. But like whenever any question would come up about infectious disease of any kind, Dr. Wilson knows the answer. And there was a period where we were working together where people were worried about Ebola in the United States. This might be before some of your time. There was a big outbreak in West Africa, and there was a lot of attention to whether or not there were going to be cases here in the United States. We did have a case in Maryland because it flew in to be treated at NIH. And then there were like these possible cases that would come up. And what would happen is they would say like, oh, we're gonna evaluate a patient, and somehow the news would leak, and it would be all over the news. Possible patient at the University of Maryland, possible patient at Johns Hopkins. And I would call Lucy, who knew all the details, and I'd be like, Lucy, is this gonna be a case? And she'd go, no. And it never was. So anyway, that was, she would know the details. And there, I can say that having worked with infectious disease doctors in many settings and experts in many different agencies, she is the paragon of expert in my mind. Let me also just briefly say I noticed that I got the photo credit on the photo provided by Dr. Sharfstein. So you might be wondering, why did he send this photo? My brother gave me a hard time for this very photo last night, so I feel obligated. He said, that's called Josh from corporate. He said, why did you send me on my phone Josh from corporate? Don't you have a normal picture? So I will just apologize. That's like my go-to photo these days. Okay, so I'm gonna talk about putting the public back in public health. And I will confess that I work at a school where there are a lot of experts, like you bump into someone in the hall and all they're doing is a particular type of water quality or a particular pathogen, and I'm like, an inch deep and a mile wide. I get involved in all kinds of different things, partly because my career was in the public sector, where the health commissioner of Baltimore, you can't be a specialist in something, or you work at the FDA or for the state. So that just gives me the ability to take a step back and think more broadly, but it's also a weakness because by the third follow-up question, you'll see how little I know about any topic that I do. All right, here we go. So what is public health? This is my favorite definition from the Institute of Medicine in 1988. What society does collectively to assure the conditions for people to be healthy. And you'll notice that there are three words in here that I particularly like: society, collectively, and people. So it is not clinical medicine, one-on-one treatment. It's not talking to one person, just isolated, which might be counseling, which can be very important, but that's not really public health. Public health is what society does collectively to assure the conditions for people to be healthy. And if you've been following the news or awake during the pandemic, you'll notice that there's a lot of angst right now about this idea that we can do things collectively to assure the conditions in which we can be healthy, right? And so much opposition to different public health measures, public health officials under attack, people marching around on their lawns with guns, or even shooting into their houses, or driving them off the road. All those things were at least alleged to have happened during COVID. Hundreds of people fired from their jobs. And then you have this idea of crisis of trust in public health. Do people believe in the vaccine anymore? Do they believe when a public health official says something? I was on a meeting earlier today. I'm on the advisory committee to the director of CDC, and there was a whole discussion of what can be done for better communication to enhance trust. How can CDC do this better? It's just on everybody's mind. So I just want to frame what I'm going to talk about in a little bit of a broad way to say, okay, why are we in this situation? And I would divide, and I'm not going to talk about all these different things, but just to kind of situate what I will talk about in this broader discussion of a crisis for public health, a crisis for our ability to do things collectively. And I think I put the challenges into two big buckets. One is outside public health, which I said is outside the house, and the other is within public health. Are there problems within public health that we have to deal with? And there's a lot of debate right now going on about these different factors. And I'll just say, outside of public health, what outside of public health is making it really hard for public health to do its job? Political interference. We have governors who are just absolutely nasty to public health officials these days. You have misinformation, which is incredibly rampant, not just on Facebook or Instagram, but you have entire circles of WhatsApp that are closed circles of communication where it's just tons of misinformation being exchanged, a lot of misinformation all over the world, some of it coming here. This is just a recent poll. Most Americans encounter health misinformation, and most aren't sure whether it's true or false. Political polarization. We're seeing vaccines get kind of lined up by which political party you're in is sort of very predictive now in some areas of whether you've gotten vaccinated, and that's not a good thing for the field. So there's a lot going on outside in the world where public health is affected. Sometimes I think of that as that's the dog and we're the tail. We're getting wagged by political interference, by misinformation, by polarization. But there's also, all that can be true, and we can also say, what can we do better? The part that we're the dog and we have more agency. And there are three different general ideas that have come up, one of which is that public health is suffering from a crisis in illiberalism, and there's a book to that effect that just came out. Another is that there's been insufficient connection to communities, and the third is that there's been inadequate public engagement. And let me just say that I don't think I fully agree with the illiberalism critique. We're going to have a podcast where I interview the author of the book. You can decide whether you think his argument is stronger than mine. I would say he's very focused on a lot of social media kind of exchanges and how people can be quite, I don't know, pointed in their social media exchanges. That would be an understatement, and really not be open to hearing what evidence might be on different topics. I don't think, though, that was really a fundamental problem with the vast majority of the field of public health. That is my view, but you can see what you think. And I'm not going to get into that in more detail during my talk, but I'd be happy to talk about it if that's of interest to you. Any questions? I want to talk about these last two, which I really do think really fall under putting the public back in public health. One, insufficient connection to communities for the field of public health, and the other, inadequate public engagement. And my contention to you is that these are really important for public health. I don't know whether it'll be enough. I don't know whether there's things that are, where we're getting lagged, where it's the interference or misinformation or polarization, whether those are gonna be so important and our society is gonna have all these problems that public health really can't do enough itself. But I do think these are really important and will put public health in the best position to succeed. So why is there a gap between public health and community? Let me start there, and then I'll talk about some of the solutions, I think. One of them is the legacy of past abuses. This was a headline, I think, in the Los Angeles Times. We want to study you for Black Angelinos. Coronavirus triggers fear of another Tuskegee. So the history of medicine and of public health, this was actually a public health study, Tuskegee, run by the U.S. Public Health Service, is a history of abuses and racism, and that impact lingers. And it's one reason that there's a gap. And I'm not even saying that there aren't problems today, maybe not quite as blatant as Tuskegee, but I think that is something that any public health official or public health researcher has to be aware of if you're thinking about how we work with communities. Another reason is inadequate resources for health departments. So between 2009 and 2020, health departments lost 40,000 workers. That means fewer positions for community health outreach, fewer resources for community partners, less time to be able to sit down and really work with communities about issues that they care about, and that really puts a lot of stress. It's very hard if you have a bare bones staff and you have to do certain things to be able to do the job of public health well. We wrote a piece called The Patchwork U.S. Health System, Public Health System. In the United States, there's a massive amount of variation in the public health system. So maybe someone could name a public health department that you guys work with. What's a public health department?
The General Child Health.
Yeah, that's maybe a division of a public health department. What's an actual public health department that you have engaged with? Yeah.
The Maryland Public Health
Good.
Department.
Excellent. So Maryland has a public health department. Every state has one. Any others?
Baltimore.
Baltimore.
Both.
Baltimore County Health Department. Okay, Baltimore County. In Maryland, every county has a health department. Is that true in the rest of the country? That every county has a health department? No. Sometimes there are town health departments. Sometimes there's only a state health department and no county health departments. There's total variation. And some of these are reasonably well funded, some of them are incredibly poorly funded. In some states you have lots of tiny little health departments that really can't do that much. Sometimes the health departments have boards, sometimes they're appointed officials. It's just a total mismatch. And you really saw that during COVID, that some areas were really able to respond quickly, and others have just enormous struggles in doing it. And so we have this very irregular map of public health, and one of the consequences of that is that there certainly are health departments that I think do a better job of community engagement, but there are many that do not. Another major challenge is that the core human resource structures in public health departments, and I'll say not just there, in academic institutions too, don't make it easy to hire community members. So if you were to say, like, one of the, why is there such a divide? Why can't we work together? Why can't we hire people from communities to do studies or to, collaborate on different initiatives? One of the big reasons is there's just not the HR infrastructure. There are not job descriptions. There are not promotion pathways. This is an article about global health workers where they said only God can thank you, but it is very much the case also in the United States that people do a lot of community health work, but in the informal sector. They don't actually have jobs. And so that also creates a gap. And then you have research. Research projects can be done, and I'll talk about better ways and worse ways to do research projects, but even today, research projects can be real irritants in, and again, I'm understating the case here, in relationships between institutions and their communities. You can have a failure to collaborate in a proposal, no clarity in expectations. People can feel exploited if the researcher comes in with a big grant and there's a lot of work for the community to do, and then the researcher goes off and publishes the paper and gets the acclaim. And then the intervention can end abruptly when the grant does, without the community really being better off. So these are all reasons why this has been a gap, and a gap that I think really became clear in many places during the pandemic. Some of you may remember Dr. Lena Wen, now of CNN and the Washington Post. She was the Baltimore City Health Commissioner. In the wake of the unrest following Freddie Gray's murder in Baltimore, she was the health commissioner. That was, I think, in 2015. And she, there were parts of the city that got shut down because of all the violence, and she sent health department workers out. And she reported that when they knocked on people's doors, people asked, are you here for a candidate? And they said no. And then they asked, are you here for a study? And kind of channeling her, she'd say, like, what an indictment of public health and academic kind of infrastructure. That's how people think, that, like, it's just people come and they need something, either for you to vote for something or for you to sign up to be a subject in something, and that's when they show up. So I'm gonna talk a little bit about what to do. And in all of these examples, I think I will say that there is a lot to do and there's a lot that's being done. But I just wanted to start here by saying, that the challenges that we have in public health, that lack of trust that got exacerbated during the pandemic, in my opinion, they relate to this underlying and long-standing challenge between public health enterprise and communities that are supposed to be the people who are getting better conditions of health. And among the different solutions to that are diversifying health professions in the public health workforce. And this is a report from the Black Coalition Against COVID, where they talk about many different initiatives. When the Biden administration came in particularly, they funded efforts to support community organizations, not just public health departments, but community organizations to go and talk about the vaccine, and actually had a huge impact on closing the gaps in vaccination. Just a little bit of history. Initially, when the COVID vaccine became available, there were immediately, for example, racial gaps in access to vaccination. In Maryland, there were huge racial gaps in access to vaccination. And people at one point, the then governor said something to the effect of, we can't make them go get vaccinated. I don't want to paraphrase there. So sort of like, this has to do with the uptake. It is not to do with access. And that was not true. That it was very much to do with access. They actually were supposed to be giving out vaccines in proportion to the population, basically. And they were giving out a lot fewer vaccines to counties with predominantly Black populations for use in their populations. Voted as community health workers because they love the job of working in their community, helping it become healthier in a very local way. And so there's a lot of interest in developing career tracks that people get promoted within that kind of work and ultimately get to management and policy level. But those have not been widely implemented yet. And then finally, and this is what I want to talk more about, or I've been asked to talk more about, is that there really needs to be a strong commitment to community engagement by academic institutions. And this is something that is very much part of my world now in the job that I have. Recently, we wrote a review on enhancing community engagement by schools and programs of public health in the US. How can academic institutions be part of the solution to this broader challenge I've been talking about, and not just part of the problem? And so let's take a quick step back and say, okay, what do we really mean by community engagement? So we're an academic institution. We're going to put a definition on things. How do we do that? This is one definition that comes from the CDC. It's the process of working collaboratively with and through groups of people affiliated by geographic proximity, special interest, or similar situations to address issues affecting the well-being of those people. The word "those" is really important in that sentence, right? It's actually working collaboratively with people about their health. And the community can be a geographic community, it can be a community by religion, by race or ethnicity, by employment, but you're working with that community. That is community engagement. It says it often involves partnerships and coalitions that mobilize resources and influence systems, change relationships among partners, and serve as catalysts for changing policies, programs, and practices. So it is not just telling people what they can do to make health. It's never wrong to tell people not to smoke, to eat better, to exercise. I won't ever say that that's bad advice for anyone, but that is not community engagement, right? Community engagement is really figuring out what the issues for health are in the community by listening to people, working with them, coming up with an agenda. Some of that can absolutely involve research as you try to figure out with them what the key questions are, and then having an agenda for change. This is an interesting graphic. I won't go through it entirely, but I'll just say that there's sort of a spectrum of community engagement. So you could imagine a project where it's just a researcher who goes out and tells a community what they're doing. Better than not telling the community, but that's one-way communication, right? Then you have somewhere, okay, we're thinking of doing this kind of project, and this could be an academic researcher or a public health department. We want to hear your thoughts about it. Okay, so that's sort of like the next level up. You can have one where you're not just getting consultation, but you're actually working in the management of the project. Then you have where the ideas for the project are coming from communities, and ultimately you have a governance structure where there's power shared for whatever project you're working on, and there's real integration between the community and the public health entity to get progress made. So that brings us to what academic institutions can do to facilitate community engagement. How do you think about that? And I'm gonna organize what I say here around what I think academic institutions do. Education, research, and practice. To me, those are like three really big things for academic institutions to do. Education, is central to the idea of what an academic institution is supposed to be doing research. Many research institutions are trying to improve the world through research, and practice is actually getting out into the world and trying to make it a better place. So under education, a critically important opportunity for academic institutions is critical service learning, which is a kind of learning where people actually are learning from community organizations and working with community organizations as they're learning about public health. And at our school, we have a number of classes that are designated as community service courses. We have training for faculty and community leaders in how to put together one of those courses, and they're pretty popular. here are some of the principles that we use: incorporating critical reflection, centering efforts on social justice, correcting power imbalances, informing genuine connections. And in our paper, we have a bunch of references about like how to do critical service learning. And I think it's important, and our goal at School of Public Health is to grow those number of courses and to have more students actually engaged in really genuine community engagement activity while they're students. Also on here, you'll see instruction on structural racism and discrimination. You know, I think it's really important for students to have an appreciation for the communities that are around the schools and their strengths and how those communities have in many ways suffered over time. And at the School of Public Health, I'll just say that in years past, people have said, this was before my time, that the instruction people got on the community was like which areas not to go in, because it was unsafe. And we now have our service learning organization called SOURCE organize a whole welcome for the students. We have community members who do tours, and some of the community members who were previously protested the school for how it treated the students or how it taught the students about the community are actually giving the tours. And it's just a small step, but the hope is that people really see the community much more with the communities that they're working with. And among some of the things that they do, there's a whole methodology for doing that kind of research, recognizing that you're not just finding people in the community. I'm just gonna tell you, we once had a faculty member who wanted to do a project and in Baltimore, and I think had a student Google community organizations in Baltimore in order to find a partner, which is not maybe the highly recommended way of going about it. And a community-based participatory researcher would already have connections, probably would be able to work through relationships to understand who partners are. But basically, these researchers are developing the project with community members. They're identifying a question that people really care about. And then they are sharing the resources that come with the project, and they are committing to share the results and to be part of the dissemination with the community. So it may be a question that is of a lot of interest to people. You know, what is the origin of the transportation challenges that Baltimore City has? Or is the soil able to sustain farming in the city? I think that's a really interesting question. That was something that one of our researchers did with a number of community organizations, and they tested the soil, they learned about it, and they determined whether or not it was safe for farming, and by and large, most places it was. And it involves a lot of work and can be quite hard sometimes, and it can take a long time. So this is sort of like a model type of research that people do, and there are people whose entire careers are in community-based participatory research. And at the School of Public Health, we have a committee that oversees the work that happens in Baltimore, called the Baltimore Community Engagement Committee. It has representation from each of our schools and departments, as well as some community members on the committee. We hear about different projects. It oversees sort of the policies. It doesn't oversee individual projects, but we have a set of best practices that we expect projects that work in Baltimore to have, including sharing vision and values. This is interesting because recently a couple researchers wanted to help a community organization in West Baltimore assess its program on research and evaluation. So there's a community organization that wants to know whether what it's doing is working. And they came to us and they said, you know, can you help us? And I found some researchers who I thought would be good to work with them. And following this guidance, the researchers wrote out, here's how we're gonna do it. Here's your role. Here's, you know, they said, does this look right to you? Let's just set the boundaries of our discussion before we get going. And the community organizations leader called me and said, that was a weird discussion. I've never had that kind of discussion before. And I said, well, how did it feel to you? What did you think? And he said, oh, it's great. You know, and that really helped us understand what we're doing, and that project turned out to be a really big success. But under each of these on our website, you can see what different best practices are. And we have we've started what I would call a continuous quality improvement effort here, which is that we've interviewed a number of our community partners, a number of the researchers. We've identified things that the school can do better. We recognize there's a lot that we can do better. And our goal is to continue to try to strengthen and develop good collaborations that get closer to the best practices. And then the third area I talk about is practice. We do education, research, and practice. So you are at an academic institution, you want to get involved in helping your county or your city or your state do something. You know, how can you do that? Well, certainly they may call and ask you to consult. One of the great opportunities that exists is called a collective impact project. How many people here are familiar with collective impact? It's also a kind of methodology where you have a broad goal, you bring all kinds of people together with different sets of skills, and you respect everyone who shows up. You know, we have health economists, but we also have community organizations that are, you know, knee-deep in the actual challenges and have a lot of insight on what can be done about that challenge. And then you set a goal, and you then develop programs and policies to try to move that forward. And I think I have maybe the next slide. Yeah. So one of the collective impact projects that exists in Baltimore City is called Be More for Healthy Babies. It's the city's infant mortality reduction effort. How many of you have heard of Be More for Healthy Babies? Yeah, so that started when I was at the health department. And it started because we realized that we weren't making progress on infant mortality. And infant mortality is the number of deaths among babies in the first year of life, number rate per thousand. And Baltimore had one of the higher ones for cities, and we had a 5-fold gap between black and white babies in the city. Black babies were dying at 5 times the rate. Just awful. One year, when I was the health commissioner, we did a press release about 27 preventable infant deaths in the city, and nobody covered it, at least in my recollection. And I was just very, very upsetting. And what is going wrong? We had a big focus on sleep-related deaths, and those are babies who were, die face down in the crib, or maybe smushed into the couch cushions, or a parent rolls over them, and we had a lot in Baltimore. And our strategy had been to really focus on the birthing hospitals, so that parents got the education, the one-on-one education, to make sure they put their kids to sleep the right way. Okay, so this is kind of like a little bit of the one-on-one, not maybe as much of a public health strategy by my definition of public health, but we tried everything, okay? We trained all the nurses. We sent out a team to train all the nurses in the newborn nursery, okay? We gave every baby born in the city of Baltimore a little onesie that said, if I'm sleeping, turn me over. Okay, so, exactly, sounds super cute, did not work, as far as I can tell. The third thing they did was, I used to be the chair of a meeting every month called the Infant Mortality Review. The Child Fatality Review is called. It was in Mercy Hospital. The absolute worst meeting. We reviewed every preventable death of a baby, or a child under 18 in Baltimore. And we had multiple agencies, and we would look at the autopsy and we'd talk it over and we'd see what could be done. And every time I had a baby that died through that of a sleep-related death, I would write that day to the hospital where they were born, and I would say, baby Josh died of sleep-related death, and I'm sure you taught their parents well, but if you could just use this as an example, have an all-staff meeting, bring everyone together, say, this is why we're doing it, and people would write me back, we don't take it personally, and thanks for letting us know. We remember baby Josh, we're so sorry this happened. We'll redouble our efforts. So everybody was trying, and no real success. And at that point, we decided that we really needed to change our strategy. We needed more of a public health strategy. And I wound up hiring someone who had done global public health work. And she was, in the interview, I asked, what do you think of our strategy so far? And she said, no offense, but your entire model is you're going to convince people in the most exhausting 24 hours or 48 hours of their lives to do something, and you're not thinking about how we really build a community coalition and engagement in order to change this. And she was hired and she built Be More for Healthy Babies, which is a coalition of over 100 organizations in the city. And they started by focusing on safe sleep, but they did it very differently. They worked with parents who lost kids in unsafe sleep in Baltimore, and they were telling their stories. They worked with grandparents. They worked with a lot of community members. They got all kinds of interesting information out. And then they progressed to more structural issues, including the ability of women to get jobs, to support their families, particularly, and as well as training for other family members. They had a whole dad's initiative. The University of Maryland School of Social Work were absolute heroes. They got a big grant in West Baltimore, and they developed a very collaborative program there that actually drove the infant mortality rate in that area below the city average, where it had been like 3 times the city average before. And that was a very comprehensive effort. The Center for Communications Programs at Johns Hopkins played its role. They designed some of those communications that were played in jury rooms and on TV and other places to get key messages across. And Morgan State was deeply involved and actually has picked up the baton for spreading some of this work nationally. So collective impact projects are where it's not like the academic institution showing up and saying like, great news, we're here to solve this problem for you. It's more like, okay, we need someone who really can design a great video to help, and here are the people who are going to work on it, and we need leadership from the social work school to help bring in resources, but then to partner with different communities. And there are criteria for how you do a collective impact kind of project, and these are great things for universities to participate in and be really a partner, and it can be extremely effective for the organization. Communities can feel great about it, and the public sector can feel great about it. This talks about 5 principles: common agenda, shared measurement, mutually reinforcing activities, although different partners play different roles. Their activities are strategically linked, continuous communication, and backbone support. So there's an infrastructure in the middle. Just a small example of just my own work, in addition to trying to support the structures at the School of Public Health that can sustain good community engagement. I always like to have my own projects. This is some work that I have done. I'm not going to show you the whole thing, just as a little teeny example. I'm very interested in school infrastructure and the conditions of public schools. And one of the major issues for Baltimore City is that the K-12 schools, while there are a few new ones, most of them are pretty old. And that creates all kinds of problems for the educational environment. During the pandemic, it turns out the state of Maryland sent people out with, in my mind, clipboards. There were probably iPads or something. And they did like a full inspection of every building, K-12 in the whole state. And we got a hold of that database. And so with some students and some researchers at the School of Education and a group that they convened that included community members, we have really dug into the data to understand it. And among the different things that we found are differences between Baltimore City and the rest of the state. Interestingly, at one point, the state was arguing that Baltimore City schools were above average for the state in terms of their physical infrastructure, and I do not think that is true. I think the data that we found demonstrates it's not true, but this is just one example. We were able to look at the actual components, every component in every school in the entire state, and ask, which were 30 years past their lifespan. Like if you have like a 20-year roof and it's now year 50, and Baltimore City just swamped the rest of the state for that, as well as 20 years and other things. So I know I'm covering a lot here. I guess I feel like I'm on a roll and I should finish and then take questions, although I would like to see what's on your mind now. But let me give you the last part of this here. So we covered insufficient connection to communities a little bit. That there's a lot of work to be done, a lot of work for health departments. And it's pretty exciting what's happening. Today at the CDC meeting, there's a whole new round of grants that's going out intended to help health departments collaborate with community organizations. So a lot of this work is happening. A lot of momentum for community-based participatory research, for collective impact projects. Let me just go to this last point, which is inadequate public engagement. And now you're kind of just getting my view on this, which is I think that it's very exciting in an emergency to take over, you know, and to issue orders. And sometimes you have to do that in public health. You know, it is, however, not a great thing to keep doing, because then if people don't like it, they get very angry, you know. And so it's really important for public health, if it's absolutely necessary to make a decision, like, you know, COVID's just happening and you don't know what's going on and you've got to make a decision, that really has to be done under time pressure and explained after the fact. But for the most part, people don't love hearing about your decision and why you did it after they're already dealing with the consequences. If you think about that in your own life, you know, like if UMBC, you know, tomorrow said, we've completely changed how we calculate whether you're gonna, you know, how many credits you need, be like, wow, I'm learning about that at the same time I have to deal with it. That's just not something that goes well. And it really doesn't go well when you're dealing with people's lives like you are in public health. And so I think that it's important whenever you have time to try as a public health agency to put out proposals, to listen to people, to think through with people what those difficult trade-offs are. Classic thing the FDA would do, this is partly from my experience, the FDA would just jump out with something and just get hammered on all sides by people who were furious from their perspective and not seeing any of the other perspectives. And one of my favorite days was there would be a story criticizing an FDA decision from one perspective, like this is terrible and indicates the FDA's in the pocket of the pharmaceutical industry and doesn't care about drug safety. And on the other page, a different reporter would write the story like, FDA criticized for being too conservative and too afraid of problems and not letting any drugs be approved. And you would have that like on the different page. Nobody would understand what the FDA was doing, and the FDA would just announce decisions. And I just think that that is not conducive to trust, right? This is all about this crisis in public health, and that through transparency and engagement, you can do more. So let me just say that, yes, this is what I just said. I think the best practice is to make the case first, explain the challenges that you're facing, sometimes ask the public for help when there is conflicting information, be transparent, provide opportunities for engagement, and then respond to criticism. Don't just get the comments and then bulldoze your way through, but listen to the comments, respond to them, if necessary, alter your approach a little bit. It can go a long way. People, and you know, I have an intuition about this because, you know, as a health official, people would call me and be very upset. And if they had heard about it ahead of time and they knew where I was coming from and they knew I'd given them a chance, they were much more willing to accept something, even if they didn't fully agree with it. Let's see. I think this is just some of the benefits of doing this, including that if you get sued, turns out that if you listen to people and you've thought about their objections, it turns into a defense for you. But I do think that it can fundamentally help enhance trust. The other thing is, I have this first bullet here, public officials can redirect objections to the process. If people go out and try to do things, you know, and it appears arbitrary, there could be a great thought behind the scenes, but if it appears arbitrary, outside people who are upset will try to get around the process. You know, they'll call friends, they'll call legislators, people will try to penetrate the process because they're so frustrated. But if you have a process that people understand, people can say, well, isn't there a public meeting on that? Isn't there an opportunity to testify on that? And it just makes it less likely that you get kind of the more corrosive types of interference. So to make my case, I'm going to give you an example of abortion. Okay, so when I was at the health department with Dr. Wilson, there was a moment where there was a case of a late-term abortion where the patient, I believe, started the abortion with the doctor in a different state. They drove to Maryland. It was a kind of a total nightmare outcome. And in the wake of that case, there was a lot of pressure for the state of Maryland to regulate abortions. And by regulate abortions, abortions are regulated, generally speaking, in most places by the medical license. So you need to have a medical license to do abortions, and if you do a bad job, you could lose your license. But this was, we need more. That was the idea. And should there be a law about that? And it turned out we had authority under the law to issue regulations. We just never done it. Regulations to protect the health of the person getting the abortion and to make sure that at the same time recognizing the need for access to abortion services. And so we set up a public process to do this. This is like one of the most fraught issues. And in many other states, you know, abortion was just a total political football through the regulatory process. It was being weaponized by people who wanted to stop abortions. They put all kinds of requirements on abortions, but that was not our goal. And we signaled we really want to do this as well as we can. We had meetings with experts in multiple disciplines. We actually put out drafts of regulations even before we needed to. We created new, ways for people to explain what they wanted. Fran Phillips, the Deputy Secretary, was just phenomenal in leading this process. She met with people, she listened to people's perspectives. And when the final rule was published about a year afterwards, we started this process with a lot of engagement. We actually got praised by both sides of the political debate on abortion. So, not that easy. You go around to different places, find something on abortion where you get a positive comment from the Respect for Life, the division of the Maryland Catholic Conference, and officials of Planned Parenthood. Not that easy to find that. And Fran Phillips did just a phenomenal job, in part because she did a lot of public engagement. I can't promise that everything is going to turn out this way, but I do think that there are missed opportunities, and you start in the pandemic, because it's an amazing crisis at the moment. But over time, you realize, well, maybe you could have taken a little bit more public comment or brought people in or talked about the challenges and the trade-offs and tried to be more engaging. I think that probably would have been a better strategy. And I think that going forward, I think public health really needs to develop those tools more effectively. So my conclusions, I think public health is facing an enormous post-pandemic challenge. Restoring community and public connection are critical pieces to regaining trust, and that's true for the academic sphere as it is for the public sector. And there's just a lot of work to be done in this area. And I think public health is an amazing field. When I was health commissioner, I got to wake up, walk around Baltimore, and feel responsible for the health of everybody in the city. It's incredible. It's just such an amazing privilege to be in that kind of role. I would get a text message every time anyone got shot in the city. We developed some of the first anti-violence programs that were effective in Baltimore, community-based anti-violence programs. We at the state, we were able to do some just really interesting things that hopefully will continue to pay off for people's health in all kinds of different ways. And so it's an incredible field. But for us to be successful at this really difficult moment, we have to put the public back in public health. So thank you very much for having me. I'm happy to speak.
We have about 15 minutes for questions.
Yeah.
So, in the Thank you for a lovely talk. Within the examples you provided, you focused a lot on public health's role with children and public health roles with infectious disease. Can you speak a little bit more about public health's roles with chronic conditions and with older populations who may be less engaged in the public process?
Sure. Well, chronic conditions are the #1 reason for declining life expectancy in the United States, and I'm sure it's still the case. When I was health commissioner, chronic conditions were the #1 reason for the racial disparity in life expectancy. And there are multiple ways that public health can engage with that. There's different levels of upstream prevention. If you think about access to food, for example, access to exercise, those are really core elements of a healthy life, and they're not evenly distributed, to say the least. And so public health efforts to understand that, the epidemiology, that's really important, as well as the advocacy and policy necessary to accomplish that. But you also can think a little bit further downstream. I think public health has a really important role in speaking to the medical system. We spend an awful lot of money in this country for health. We do not get the outcomes that other countries do, right? In a different talk, I show a graph of healthcare costs against life expectancy, right? And you see that generally speaking, as you spend more on healthcare, life expectancy goes up, and then the United States is like in a timeout. Every country, in the United States is like way over here for low life expectancy, high cost, the highest cost, and we're like somewhere between 40th and 60th in life expectancy. I think we're like 45th headed towards 60th. And it's, what is going on there? Our healthcare system is not organized to fairly deliver good outcomes. So I think public health is a really important role in thinking about how to do that. So there's a lot of work for public health in those areas. We spend a lot of time on it. Yeah.
Hi, my name is Smita Prabhu, and I'm a PhD student in the Department of Public Policy. I really appreciated hearing about your work working with Dr. Tarasa in the Baltimore City Commission during the pandemic. I was someone that was in the maternal child health department as we were working on identifying vaccine ambassadors and recruiting them to be able to spread positive messages about vaccine uptake. You mentioned a challenge currently about future funding being very uncertain, despite the fact that it's very effective in collaborating with established organizations. In your experience, how do we bridge this gap in established organizations and these organizations accessing those grants? And the reason why I ask this question is in this example of the amazing organizations in Baltimore City, we have an ongoing opioid epidemic, right? And there's the Maryland Department of Health, the Baltimore City Health Department. There's also really cool organizations like the Bridges or Baltimore Harm Reduction Coalition. And these are small nonprofits that were demanded a lot of work during the pandemic and post. But these are also organizations that don't have as much manpower or like grant literacy or even the technology to access such grants that might be coming from the state or federal. So I wanted to hear from your experience, how do we bridge this gap of established organizations accessing those funds to be able to continue that collective impact you speak about?
Sure, terrific question, and thank you for your work during the pandemic. That's really important. So I think what you're describing is the challenge. It is a huge challenge. It's what CBC was talking about today in my meeting. How does this get sustained? And I think public health is still riding on the coattails of extra pandemic funding and hasn't figured out sustainability for this kind of work. I think it's a really important thing from a policy perspective. And from a research perspective, it's really important to document the importance of it so that it supports sustainable funding. Each area that we talk about has its own story. The story of addiction funding in Maryland is pretty interesting. Maryland provides more state funding for addiction than I think any other state in the country. And the history of that goes back to when Martin O'Malley was mayor the first time, and he asked the governor for a huge amount of funding for addiction. And the governor created this big state grant program, which still exists. And one of the benefits of that is that there's a lot of flexible funding that comes into Baltimore for addiction. There's no flexible funding that comes for other things, really, at least not from the state. But for addiction, there is, and there's an organization that goes not just to the city, but also to county, where there's an addiction problem too. Their money goes to these different councils. In Baltimore, it's called Behavioral Health System Baltimore now. And they decide where to spend the money. They used to have to spend it all on treatment, but because insurance expanded, and Medicaid covers addiction treatment, they don't have to spend it on treatment. They can spend it on other things. When I was the health commissioner, we spent it to pay for the training of every doctor for buprenorphine and to pay community organizations to work with drug treatment centers to find people and get them treated for addiction. So it's a slightly different story. Like, there is sustainable state funding in addiction that doesn't exist in other areas, which is why I would just flag that. But I wouldn't say that there's truly a collective impact strategy on addiction yet in the city. And I think that's, if you compare what we've done in infant mortality in the city to some of the other areas, I think infant mortality is a model that needs to be replicated more. And that might have implications for how this kind of work could be better done. And I do think it's an opportunity because there is actually a funding source where there isn't on other things. The issue that you've mentioned about grant literacy, I'll just take that too. So has anyone heard the term Beltway Bandit? Yeah, anyone, Beltway Bandit? Beltway Bandits are organizations that are like highly evolved organizations for getting federal grants, hence the Beltway part. And so you might find that like major defense contractors are getting public health contracts, and that's because they know exactly the words, how to put things forward, and they'll hire the right staff, and they will go after whatever grant. But a community organization, it's not so easy to have the right kinds of insurances and figure out the right way to file in the computer system and all these different things. So, and that problem is not just a federal problem; it's just sort of replicated throughout the system. And this is a challenge. It's a big challenge. When I was a health commissioner, there were multiple small organizations that folded because they had trouble with grants-based accounting, which can be very complicated. And that is something that there have been solutions to that have come up that turned out to not be solutions. I think the challenge is that when you're giving out larger amounts of money, oftentimes larger than what organizations typically have used, they may not have the systems in place yet to be able to manage them. And so a critical policy solution isn't to say, well, then those programs shouldn't get funded. It's how do you support those programs in getting funded? What kind of infrastructure can be put into place for that? And we could talk more, but that is what there are organizations working on trying to do that. There's some that are in place, but that's really an important bridge between organizations on the front lines and the funding that can come in to help. Yeah.
Yeah, I'm Zach Starr, master's student in public policy. My question is, in these kind of like collective advocacy efforts, how do we balance the wishes of the community with kind of pragmatic and political considerations? I'm thinking specifically of something like the Access to Care Act that has moved through the state legislature, if you're familiar with it. Because with that bill, the community obviously wants a much more expansive, they kind of passed it for 3 years now, and it's failed again and again in the state legislature, and they want something more expansive than kind of what has been provided. So how do we kind of find that balancing act there?
Sure. I would say that an advocacy campaign is not quite the same as collective impact. But your point is a good one, which is, look, you're doing community engagement. What happens when you have different perspectives? And I'll tell you, I was once at this event where I got seated with other faculty somewhere else from Johns Hopkins, and the topic came up, and someone said, I'll give you an even more extreme example than what you're talking about. And somebody said, the most important thing is to listen to people in the community no matter what. And it turned out this person was a researcher on vaccines. I said, well, what if the community says they don't want vaccines? And then they went, well, hold on a second. It's like, it's a little more complicated, right? And in the issue of addiction, there's a huge challenge of very, very negative stigmatizing attitudes towards people with addiction. they're not universally held in communities, but are certainly you could hear them in areas. My wife works in an great nonprofit addiction treatment program in Baltimore City, and their neighbors running around taking pictures of people at one point, going into to get treatment. And so, it's a little gets a little complicated on some of those issues. It's a little different when you're ready, but I'll just raise that as like, they're hard things sometimes you have to work out. And there's sometimes lines that have to be drawn if you're committed to doing things that are based on evidence. But ideally, you have a good relationship with people. You can be honest, and you can explain, your thinking and listen to what people are thinking. On the issue of the Access to Care Act, which is about providing health insurance for people who are undocumented, the proposal last year would have given access to the exchange with some funding for subsidies. This year, it's just access to the exchange, no funding for subsidies. And, people who say, well, how is this really gonna help my parent, my child, it's a really serious thing to listen to and contemplate. And there's no easy answer to that question, but what you have in Maryland is a very trusted community organization in CASA that can broker those conversations and say, like, look, this is a strategy we're taking, and people will have to trust it. I think if they weren't trusted, then you wouldn't be able to get to unified advocacy. And, it's hard. This concept that like trust and credibility is just so important and almost priceless in the situation is, I'll tell you a story when we were so excited, when we actually saw the infant mortality rates fall in Baltimore. I should advise that we did this whole public health campaign, and infant mortality came down to the lowest level ever. The racial disparity really went down significantly. The number of preventable deaths, sleep-related deaths really went down. And it was like hugely successful, beyond really what I thought it would be. And the incredible person who you may have met, Rebecca, still runs, coordinates Be More for Healthy Babies, still at the health department. And what was I gonna say? I started thinking about Rebecca and immediately lost my train of thought there.
We thought it was gonna be successful, it wasn't, but.
I have to think about what I was thinking. Hold on. It will come to me. The other questions, I will circle back to them. Yeah.
I wonder for the undergraduates who are here who are intrigued by your talk and want to do something, what specific advice would you have for them? Like, how can they get involved somewhere? Like, what's their first step?
Sure. Well, for undergraduates, a great thing to do, I know you have organizations here that work with community groups, would be to engage with them, see what's interesting, go with an open mind, listen as much as you can, and have like an extracurricular kind of activity or a service learning course that's really helpful.
Any agencies, like in the city or state or organizations they might reach out to?
There are many organizations. I would let your interest drive it. If it's addiction, there's the Harm Reduction Coalition. If it's, infant mortality, it could be one of the groups that's involved in Be More for Healthy Babies. There's a whole lot of opportunity in this area. There's some really strong organizations. The best thing, at our school, SOURCE plays this sort of intermediary role where these organizations don't just have students show up. Like, the students come having been trained. The organizations can call SOURCE if there's a problem. We have this, there's a council of community organizations that works with the school and lets us know if we're doing anything wrong in how this is structured. And they can also call and say, hey, we need a student to help with the grant, or we need a student for this analysis. And so thinking about it not just as what an individual undergraduate can do, but what a school can do to support multiple undergraduates doing this and having like a longer term impact is another way to think about it. I know you have different centers that kind of focus on that, but building them up to be able to play that role is really important.